Good afternoon. Obviously, there's a lot of different topics that we could talk about in ALL, and in the interest of time, I just really picked these two. The first one, the subtype-directed approaches, because there has been some really enormous improvements in a few of the subtypes of ALL, and the new agents, because I think everybody's always interested in hearing about what's coming and what's the potential that might impact this disease. So the first subtype that I wanted to talk about is Birkett leukemia lymphoma, which, as you all know, is a mature B-cell disease and has usually a fairly classic morphologic pattern with the vacuolization that leads to that starry, starry sky pattern that many of you are familiar with and is very identifiable when you see it. This is, again, a mature B-cell disease. It's a mature B-cell because they express surface immunoglobulin, so pre-B does not. And this is a disease, and this will be relevant to what I'm going to talk about, that's highly CD20 positive also. As you know, it can be associated with EBV, more so in Asia than in the United States, and the key factor here is activation of MYC at AQ24, and so you see one of three generally classic translocations in this disease, all of them involving, however, rearrangement of the MYC gene. Now, this has a very specific morphology, which I just showed you, the L3, and this is one of the few sort of emergencies, perhaps, in treatment of acute leukemia besides, say, APL, where there really is an urgency to do something right away, and APL because of the DIC. In Birkett's because of the incredibly rapid growth that you can see with this disease. And the most notable one to me is I actually had a patient who came in the morning with, I would say, about a golf ball sized node under the arm, and by evening, that was probably about the size of a baseball. So that's a very dramatic one, but they actually can progress like that. They often have abdominal disease, involvement of the GI tract, which can be an issue in terms of perforation during remission induction. They often have lymphadenopathy, hepatosplenomegaly, markedly elevated LDH, and they can actually present with tumor lysis and low-grade renal failure even before that you give them any treatment. As you all know, this is a high likelihood of CNS involvement, and interestingly, even in people where the MRIs are negative and the TAPs are clean, probably 1 out of every 2 patients has CHIM numbness. And this is a very consistent finding in Birkett's and sometimes can take several cycles to go away and doesn't actually correlate with the presence of overt disease in the CSF. Now, what we do know is that this is a disease, and I'll show you that in the next slide, where historically regular ALL therapy worked very poorly. In the Burkitt's lymphoma, even without a leukemic phase, say the standard regimen that one might use for large cell lymphoma, such as CHOP rituximab, worked very poorly. We know these patients need tumor lysis prophylaxis, and this is the one subtype of ALL where we do not give maintenance therapy. This is from a publication from Dieter Holzers in 1996, so this was about 15 years ago, and that dismal curve that was sort of falling off immediately was the treatment of Birkett lymphoma or Birkett leukemia, and the curves that look fairly good are non-Hodgkin's lymphoma treated with similar regimens. So what this made very clear is lymphoma and standard ALL regimens were not effective, and we know that part of the reason for that is that, again, what I mentioned previously, that these are very proliferative diseases. And so if you think about the way most regimens for ALL are given, they're, a series of drugs, daunorubicin, vincristine, steroids, but strung out over kind of an extended period of time. And when you have a very rapidly proliferating disease, that's just not going to cut it. This is data that was published in 2001 from CALGB showing now a very different curve than what I just showed you from about 5 to 10 years before that, now showing what looks to be a plateau on the survival curve of about 50%. And what evidenced this very dramatic change in the prognosis of the disease was the recognition that standard ALL treatments weren't going to work, and because of the proliferative nature, we needed very high-intensity, short-course treatment. And so again, with most of the treatments that we use for Birkett, we can be done in about 6 months, and no maintenance therapy is needed. This is a number of series, including European series, CLGB, data from MD Anderson and Debbie Thomas, showing that with this type of approach, we went from almost no cure fraction with this disease to about 50%, which is pretty good, but obviously the implication then is that, well, one out of every 2 patients is still succumbing to complications of the disease, and further improvement could certainly be found. And where that improvement seems to be coming is from a very simple addition to the chemotherapy, and that is the addition of rituximab. So you know that rituximab targets CD20 and is used widely as part of chemoimmunotherapy in lymphoma and CLL. And this publication that I showed you here is our own data from MD Anderson using the exact same hyper-CVAD regimen, but simply adding to the chemotherapy rituximab, and you notice the dramatic improvement in overall survival. So this is the classic hyper-CVAD regimen where we alternate hyper-CVAD, which is high-dose fractionated Cytoxan, vincristine, adriodecadron, with the even-numbered cycles, which are methotrexate and high-dose Ara-C. The way this was designed, and it was somewhat empiric, was that there were 8 doses of rituximab given, 2 with each of the first 4 cycles, and obviously intrathecal chemotherapy was given in addition, no maintenance. And this is comparing to our historical control data where, again, as I showed you in the table, the overall survival was about 50%, and now you see this very dramatic improvement in survival, again with exactly the same chemotherapy, but simply with the addition of the rituximab. We're not the only ones to show this. This is data from the Germans, where they have added rituximab to a BFM-like regimen. The BALL doesn't look quite as good there, but interestingly, in the over 55, that was because they were worried about dose intensity, and they removed intravenous high-dose methotrexate and Ara-C, and probably because of that, since both of them, as you know, crossed the blood-brain barrier, they had a very high number of CNS relapses in the older patients, and most of that reduced survival was accounted for purely by CNS relapse. But if you look at the younger patients now, you see that they were up to about 80 to 90% 3-year overall survival with the addition of antibody to the chemotherapy. And this is just a graphic depiction, again, of that dramatic improvement in survival that we see by adding on a targeted therapy, namely the rituximab. Well, it's interesting because this has really gone from sort of being one of the worst leukemias that we would see with ALL, and has now really become, except for the issues with complications and induction, which can be serious, once you get past the induction, in fact, this is a very highly curable disease. And this is our own update now with about double the patients that I showed you in the original database. So this is up to 55 patients, showing you that the overall 5-year survival with the addition of rituximab is on the order of about 75%, and probably about the highest cure rate for any subset of ALL at this point. So dramatic evolution of the outcome of this disease over 10 to 15 years, partly because of changes in chemo and partly because of the addition of targeted antibody therapy. Now, the other interesting finding is when we were looking at our patients with pre-B-ALL, we said, well, would it be worth targeting the CD20 positive patients there? So these are not Birkett's, these are pre-B-ALLs, but who express CD20. And that would account for about 30 to 40% of patients with pre-B-ALL if you use a cut point on flow of 20%, which is usually standard. This just looked at our historical experience. VAD and CVAD were regimens we used prior to hyper-CVAD, and it was pretty consistent that irrespective of the regimen over time, what we showed is that, this is historical data, that patients with pre-B-ALL who express CD20 appeared to have a significantly inferior outcome. If you look at that very last line, the 3-year overall survival with hyper-CVAD, you notice 60% in the CD20 negative versus 27% in the CD20 positive, and this is prior to rituximab. This is just showing you graphically what I just showed you in that table, the very large difference in outcome based on CD20 positivity. Now, you might be wondering if others have shown this, or this is rather particular to hyper-CVAD. Actually, the pediatric group, and this was published by Seema Jekha, looked at this in the pediatric population, was not able to reproduce this prognostic significance of CD20. And of course, we all know that sometimes prognostic factors may also be related to therapy, but I'm not aware of anyone who's tried to look at it in another adult population. So what did we do? We added the rituximab exactly as I showed you that we did it for the Birkett, but here we added it to the pre-BALL who were CD20 positive, and this is again a comparison to historical experience showing a significant improvement in CR duration with the addition of, again, just the monoclonal antibody to the exact same chemotherapy. The other subset that I want to talk about, where you all know there have been enormous improvements in outcome from what was originally considered one of the most high-risk ALLs, is Philadelphia positive disease. And of course, the hallmark of this disease is the Philadelphia chromosome, the same Philadelphia chromosome that we see in CML, although usually more commonly with the P190 seen in about 70% of patients as opposed to the P210. This is a B lineage ALL, pre-B, but they have very frequent co-expression of myeloid markers, which, by the way, has no prognostic relevance, except that if you see an older patient, and in the United States, a Latino patient in particular, who have myeloid markers, very likely that they may have Philadelphia positive disease. That's because the incidence of this disease increases with age. And this is particularly problematic when historically our only curative approach to this disease was with stem cell transplant. And yet the incidence would be higher in the older population who might be less likely to be candidates for transplant. This is a number of different series, again, both American and European, and this is pre-imatinib era, so looking at the survivals of adult patients with Ph-positive ALL, and you can see really dismal survivals on the order of 10 to 20% maximum, and again, most of that was associated with allogeneic stem cell transplant. What has changed this disease in terms of a targeted therapy? Obviously, it's imatinib or the TKIs. This was data from one of the original publications using imatinib to treat relapse refractory Ph-positive ALL or CML blast crisis. LPB is lymphoid blast crisis. And what you can see is that there were responses even to the single agent, but if you look at the time to progression of 2.2 months, you see that these responses were very transient. Now, part of that is that these were relapsed patients, but I don't think anybody thought, based on this data, that imatinib by itself would be curative even in an upfront setting without the combination of chemotherapy and imatinib. There are now quite a number of different groups who have, in different ways, combined chemotherapy regimens with imatinib. I'll show you our own data. There's very nice data from the Japanese, data from the Italians, the French, and the Germans, all using various different types of chemotherapy, but with the common theme of adding imatinib to the treatment. So again, this is our typical hyper-CVAD. Now, when we started doing this, one issue is that, well, if we were going to add imatinib, which we know is myelosuppressive, and we continued that continuously, would we have trouble with count recovery? Would we wind up in trouble because we were delaying recovery because of the added myelosuppression from the imatinib? So the gray bars there show that what we did initially was give it intermittently. So 14 days out of each cycle. And then in the maintenance phase, we gave it continuously, dropping out the more standard 6-MP and methotrexate that's part of the pump maintenance, but keeping the vincristine monthly with the bolus prednisone. Now, what we found is that, in fact, we were not delaying recovery of the counts when we added imatinib, but by the way, everybody treated with hyper-CVAD does get growth factor support. That's an obligate part of the treatment. But with growth factor support, they recovered just as quickly, and so we revised the protocol, and we only gave 14 days during the induction, because obviously they're starting leukemic, and we want them to recover quickly, and then the protocol was revised so that the imatinib is just given continuously with the standard 8 intensive cycles. And then we prolonged the maintenance, and now we actually give the imatinib indefinitely. This is, again, a comparison to our historical controls. This is looking at CR duration. So, again, the chemotherapy is exactly the same here. All we've done is add the imatinib to the hyper-CVAD, and you can see this very dramatic improvement in CR duration, which has been mirrored by a significant improvement in survival. Now, this obviously raises the question, and this was one of the questions that you answered, that Marty showed you, was, well, if we're doing so much better with imatinib, where does stem cell transplant fit in? I mentioned that historically the goal, if you could, was to try and get everybody to a stem cell transplant. Is that really the goal anymore? Well, we looked at our own data to try and parse that out. And this is data presented at ASCO in 2010. The top two curves are hyper-CVAD plus imatinib. The green are the patients who went for stem cell transplant, and this is only looking at less than age 60, since obviously if we take all comers, we'll be somewhat select. They really won't be comparable populations because 80-year-olds aren't going for a transplant. The yellow are the patients who did not have a transplant. Now, the p-value there is 0.1, so not technically significant, but I think everybody would agree that the trend is certainly there. And to sum this up, what we do still is try and get everybody to stem cell transplant. Now, what may change this, and I'm not going to show you any data on this today, is what may make us able to say, well, who might we be able to cure without the transplant, thereby foregoing the morbidity and potential mortality of that. I think maybe MRD. That may help us to sort out better who we need to send to transplant and who we don't. But as of right now, we still try and get all those patients to transplant. And again, just to show you some other data besides the MD Anderson data, we see much more improved overall survival with the addition of imatinib to chemotherapy. So in the last few minutes, I just wanted to talk about two new monoclonal antibodies that are very exciting and may have a significant impact on this disease in the future. Both of these are investigational. The first one is called inotuzumab. This is an antibody to CD22, and as you know, CD22 is highly expressed on almost every patient with ALL. So it's a nice target in an ALL population. This is an antibody that is bound to calicheamycin. Calicheamycin is a toxin which you're probably familiar with because this was the toxin that made up Mylotarg. So in Mylotarg or gemtuzumab, calicheamycin was attached to an antibody, remember, that bound CD33, which was why it was used as a treatment for AML. So here we have the same toxin, but an antibody binding CD22. And we have, this data was presented at ASH. We had 49 relapse refractory patients with ALL. Note here that 50% or more of these patients were in second salvage. So this was a pretty highly pretreated patient population. And remember, one of the difficulties with salvage therapy in ALL is that in most ALL regimens, we use essentially all of our active agents up front. Anthracyclines, Ara-C in most regimens, methotrexate, alkylating agents. So when people have relapsed, you've actually pretty much used up all the good drugs that you have, which makes this a little bit more challenging. And again, most of the patients strongly express CD22. So 49 patients were evaluable for response. If we look at the overall response rate, it was 57%, including 9 CRs, 14 CRPs, so incomplete recovery of platelets. And this is one of the known side effects of this drug from the lymphoma trials, was that you could see cumulative thrombocytopenia with this antibody. And then 5 CRI. Well, of the patients who went into cytogenetic remission, 18 of them had abnormal, of patients who went into morphologic remission, 18 have abnormal cytogenetics to begin with, so they were evaluable for cytogenetic response, and 16 of the 18, or 89%, lost their abnormal clone and became normal diploid at the time that they were in remission. We also had 27 of the 28 where we looked, 28 morphologic responders where we looked at MRD, and you can see that MRD negativity occurred. This is using 4-color flow and was much more likely to occur in true CR patients. We didn't see any in the 4 patients who only had a marrow CR. Progression-free survival and response duration are about 4 to 6 months. However, if patients get a complete remission, this can be durable, and we actually still have some patients out over a year in a complete remission who have not relapsed. Now, this is just a comparison. Again, you know that at MD Anderson we like to compare to historical controls. We have a very robust database. So this is looking at comparison of patients to patients in our database who were treated in relapse with some type of chemotherapy, and that could have been whatever regimen that we were investigating at the time. But what you see is that no matter what salvage number we look at, first salvage, second, et cetera, the antibody appeared to be significantly better than chemotherapy. And probably with this kind of a response rate in this kind of a refractory population makes this one of the most active agents that there is in ALL. And then finally, the last antibody that I want to mention is also very exciting. This is the BiTE antibody, or blinatumomab. And this is an interesting antibody because it's bispecific. So it binds to both CD3 on T cells, and it binds to CD19, again, another B cell target that's present on many B cell malignancies, including ALL. The first trial using this antibody was actually done in lymphoma. The interesting part is that when you have binding of the antibody to the T cells, you activate the T cells, and now you're directing the T cells to kill the B cells. So a nice immunologic treatment, if you will. The first paper using this in ALL that was just recently published in JCO was in patients with B-cell ALL who were MRD positive. So the Europeans have very clearly shown with their assay that if patients become MRD positive or never become MRD negative, the relapse rate is very, very high. And inevitably, they will relapse. So they focused in on that patient population. It was a small number, 21. They had 20 evaluable for response, and 16 of them achieved PCR negativity. The 3-year relapse-free survival is 78% on that trial with no further therapy. You do see fever with the drug administration, hypogammaglobulinemia, and occasionally neurologic. There have been a couple of neurologic events of uncertain etiology, such as seizures. Again, this is a more graphic depiction showing you that 80% of the patients became MRD negative, and again, many of these were high-risk patients, including those with Ph-positive disease and translocation 411. This is the disease-free survival. This compares for you all the patients versus those where they were able to get them to stem cell transplant after the blinatumomab, and you see so far with small numbers no difference in outcome. The current trial in Europe, and there's an American trial which has just opened, is now looking at relapse disease. So these are people with ALL, many multiply relapsed, but not just MRD positive. So now you have a full-blown morphologic relapse, a bone marrow full of ALL. They're looking at a couple of different dosing schedules because there's some suggestion if you start with a lower dose for the first week and then up the dose, that some of that neurologic toxicity that was seen in the prior trial is not seen. This preliminary data was presented at EHA just this past June, and you can see that with small numbers, a very encouraging complete response rate of about 75%. And again, we're the first center to open the trial in the United States. We have put 2 people on, and one of the 2 has entered a complete remission. So I think that this is a very exciting antibody that will definitely have a role in the treatment of this disease. And this is the survival now for the relapsed ALL cohorts, again looking at the different dosing schemas for the data that was presented at EHA. So the median survival had not yet been reached with a median follow-up of 10 months. So I'll stop there, and I'd be happy to take any questions about the subtype-directed therapy or some of these new antibodies. Thank you. After? Okay.